So now we are going to start with subcutaneous mycosis, and the first one that we are going to take up is sporotrichosis. So sporotrichosis is caused by, it is caused by Sporotrix shankai. Okay, so as you guys can remember, this name you have heard somewhere else. Okay, so Sporotrix shankai is a thermally dimorphic fungi. Okay, so what were thermally dimorphic fungi? Try to recall the mnemonic: his pistis, shoot, blank, checks. So Sporotheric shankai is a special thermally dimorphic fungi in a way because all the thermally dimorphic fungi are usually going to cause systemic mycosis, and this one is causing subcutaneous mycosis. So it is the only thermally dimorphic fungi which is not causing a systemic mycosis. So sporotrichosis is caused by Sporotrichs shankai, which is a thermally dimorphic fungi, and this sporotrichosis is also known as rose picker's disease or rose gardener's disease. So to help you remember that it is also known as rose picker's disease and rose gardener's disease, I have put up the beautiful picture of Rose from the Titanic. So I hope this helps. Now, in case of subcutaneous mycosis, the mode of infection is going to be traumatic inoculation with the contaminated material. Okay, so for example, this Sporotrichs shankai is usually present on, plants or wood. So the gardeners or the carpenters are usually more at risk of getting this infection. All right. So there could be any trauma which could lead to the contaminated fungal spores into the skin, and then they will invade the subcutaneous tissue, and we will see what will happen then. So let's talk about the pathogenesis of sporotrichosis. So like I just said that there could be some trauma which will lead to the fungal spores to get into your skin. So now that they are into your skin, so the fungi is now in your skin. So what is going to happen now? The fungi is going to produce two types of enzymes. Okay, so the enzymes which it is going to produce are serine proteinase and aspartic proteinase. All right, and these two enzymes which it produced is going to help it invade. Okay, it is going to help the fungi invade our subcutaneous tissue. So now that it is in our subcutaneous tissue, what will it do? It is going to not stay silent. It is going to invade more. It is going to invade our lymphatics. Okay, it is going to enter the lymphatics, and then it will lead to the inflammation, that is lymphangitis. And after this inflammation, the fungi is going to come out. Okay, so the fungi comes out, and what appears is the ulcers. Okay, so now the ulcers appear, which are present in rows. Okay, so a row of ulcer is seen on the skin and subcutaneous tissue. So why it is present in a row-like pattern or a series? Because it is invaded the lymph vessels, so it will spread across the lymphatics, right? So as you can see in this picture, these are the lesions, the nodular ulcerative lesions that we see in case of sporotrichosis. Okay, so all these lesions, they spread along the lymphatic vessels, and this spread along the lymphatic vessels is known as, this spread is known as sporotrichoid. It is known as sporotrichoid pattern of spread. All right, and this special sporotrichoid pattern of spread is not only seen in case of Sporotrichs shankai, but some other organisms, other fungi as well. Right, so here we are. This sporotrichoid pattern of spread can also be seen in Sporotrichs shankai, like we just saw, and it is also seen in case of Nocardia brasilensis and in case of Mycobacterium marinum, right, and Leishmania brasilensis. These are the common causes of the sporotrichoid spread of sporotrichoid pattern of spread, right? So now we are going to see the clinical types of sporotrichosis. There are many clinical types, but the most common one, so the most common clinical type is lymphocutaneous. About 80% of the cases are of lymphocutaneous type, And in this we are going to see the nodular ulcerative lesions like we just saw. We are going to see nodular ulcerative lesions, which by the way looks painful but are painless. Alright, so these nodular ulcerative lesions are spread across the lymphatic vessels because the fungi invade the lymphatic vessels, and these lymphatic vessels even are palpable. Okay, you can palpate these lymphatic vessels. They feel cord-like. Okay, so these are palpable. Lymph vessels are palpable. Okay, so what are the other clinical types? We have seen the most common one. So the other clinical types are, first we have osteoarticular type. Okay, osteoarticular type of sporotrichosis. It is most commonly seen in, not most commonly, but usually it is going to be seen in alcoholics. Then we have pulmonary type. Okay, which is going to be seen in patients who have an underlying chronic obstructive pulmonary disorder, and they have somehow inhaled the spores of the fungi. In those patients, we are going to see the pulmonary type of sporotrichosis. So in patients of COPD. Then we have disseminated sporotrichosis, and this disseminated sporotrichosis is actually special because first of all, it is seen in immunocompromised people, right? Like in patients of AIDS or HIV, right? Or someone who has gone under organ transplants. Right, so why is it special? See, all the clinical types of sporotrichosis that we see are going to be cured by the itraconazole that we give to the patient. But in case of disseminated sporotrichosis, we have to give amphotericin B. All right, itraconazole does not work that well. So we give the patient amphotericin B if it is a case of disseminated sporotrichosis. Now, the fourth type, we have fixed cutaneous sporotrichosis. Okay, in this there is no spread along the lymph vessels. Okay, there is a single nodular lesion, right? There is a single nodular lesion which is present, and it does not spread along the lymphatics. Alright, so this was about the pathogenesis and the clinical types. Now we are going to see how are we going to diagnose the case of sporotrichosis. Now, first of all, these sporotrichosis, by the way, are present in India, mostly in the sub-Himalayan hilly areas. Okay, so for the lab diagnosis, we are going to collect the samples, right? So the specimens that we are going to collect are the swab from the ulcer, or we can take the aspirate from the nodules. Okay, so after we have taken the specimens, what we will do, we can go for KOH mount, right? We can go for KOH mount, and we can also go for the calcofluor white stain. And what we will see is, we are going to see elongated yeast cells, right? We are going to see elongated yeast cells which are about 3 to 5 microns in diameter. But this method is a little bit less specific. Okay, so what else we can do? We can do the biopsy. We can do the histopathological examination from the aspirate or the specimen that we took. Okay, which is going to show us a very peculiar feature. Okay, we are going to see asteroid body in case of sporotrichosis when we do the biopsy, we do the histopathological examination. So what are the asteroid body that I'm talking about? See this picture. Okay, this is a asteroid body. Now let me tell you what the asteroid body is composed of. So this asteroid body is going to contain an cigar-shaped or elongated yeast cell in the center, which is, by the way, basophilic. All right, plus we see this radiating pink thing, right? This is the yeast cell that I was talking about, and this pink radiating thing that is there is nothing but an eosinophilic mass composed of the antigen antibody complex. Okay, so what it is an eosinophilic mass which is radiating surrounding the yeast cell, and it is composed of the antigen antibody complex. Okay, so asteroid body, by the way, are also seen in cases of aspergillosis or candidiasis as well. And this, by the way, this this eosinophilic mask which is surrounding the yeast cell, which is nothing but the antigen antibody complex. It is also known as splendor. It is also known as splendor Hopley phenomena. And this phenomena, splendor Hopley phenomena, is also seen in candidiasis, aspergillosis, and etc. Right. So when we do the histopathological examination, we are going to see, in case of sporotrichosis, this asteroid body, which is containing the cigar-shaped yeast cell, right? The cigar-shaped yeast cell in the center, which is basophilic, and a radiating eosinophilic mass surrounding it, which is composed of antigen and antibody complex, right? So but this is again not the most definitive thing that we want to do. As we all know, the Sporotrichosis is a dimorphic fungi, so the best way to diagnose this infection is by doing a culture. So then we can do culture on SDA, and we are going to do two cultures, okay? And we are going to do two cultures, and we are going to incubate it at 37 degrees Celsius and 25 degrees Celsius simultaneously, right? Because it's a thermally dimorphic fungi, it is going to appear yeast-like, okay? There will be yeast-like morphology on the culture at 37 degrees Celsius, and filamentous fungi morphology at the 25 degrees Celsius or the room temperature. So this is the filamentous fungi morphology that we see in case of Sporotrichosis, and we can see these slender hyphae, right? And this is the conidiophore, this stalk-like thing. This stalk-like thing arising from the septi, from the hyphae, is the conidiophore, which is containing these unicellular microconidia on its top, and it appears like a flower. Okay, so we also call it flower-like pattern. Flower-like pattern of microconidia, or you can remember rosette-like pattern. And from rosette, you can also remember that it was also known as rose picker's disease or rose gardener's disease, right? So because it is a thermally dimorphic fungi, it is going to show filamentous form at 25 degrees Celsius or the room temperature, which was, by the way, the infective form, and at 37 degrees Celsius, which is our temperature, our body temperature, it is going to appear yeast-like, right? And by the way, in histopathological examination on the tissue, the temperature is again 37 degrees Celsius. That is why we are seeing the cigar-shaped yeast cell. Now for the treatment, like I said, we are going to give itraconazole, right, in all cases except the disseminated one, right? Except disseminated sporotrichosis. Disseminated में हम क्या देंगे? We will give amphotericin B. Okay, so let's revise this once. All right. So we started the subcutaneous mycosis, and the first one that we did was sporotrichosis. Okay, and sporotrichosis is caused by Sporotrichosis, and the mechanism, the mode of infection, okay, is traumatic inoculation. Now, as we all know, the Sporotrichosis is a thermally dimorphic fungi, and this disease, sporotrichosis, is also known as rose picker's disease or rose gardener's disease. For the pathogenesis, you guys know that after it enters your skin, it is going to produce two types of enzymes, that is serine proteinase and aspartic proteinase, which will help the fungi to invade into the subcutaneous tissue, and after it is in the subcutaneous tissue, it is going to invade the lymphatics, right? And it will spread along the lymphatics. It will cause the inflammation leading to lymphangitis. Then it will come out, and we are going to see the ulcers, which are present in a row. Why it is present in a row? Because it is spread along the lymphatic vessels, the course of lymph vessels, right, like we saw here. Okay, now this spread was known as sporotrichoid pattern of spread, which is also present in some other type of fungi besides the Sporotrichosis. And the most common clinical type of sporotrichosis that we saw was lymphocutaneous sporotrichosis, which was seen about in 80% of the cases, right? And we are going to see the nodular ulcerative lesions, which are painless, right? And the other ones were osteolytic, osteoarticular type, pulmonary type, disseminated type, and fixed cutaneous type. Now for the lab diagnosis of sporotrichosis, we are going to take the samples, right? We are going to take the swab from ulcers and we aspirate from the nodules. Okay, then we will do KOH mount or calcofluor white stain, and what we will see will be elongated yeast cell, but this method is not so sensitive or specific, so we are going to do something else. So what we did was the biopsy. Okay, we did the asteroid, we did the histopathological examination, and we will see asteroid body. Okay, and you know what asteroid body is? We have a cigar shaped yeast cell in the center, and surrounding it is a eosinophilic mass which is radiating, made up of antigen antibody complex, right? But this is also not enough, because this is also seen as this Splendor Hopley phenomena. This is eosinophilic mass is also seen in case of Candidiasis and aspergillosis and some other more, right? So we are going to do one more. We could do one more thing. We could do culture of this fungi, because it is a thermally dimorphic fungi. We will culture it on SDA at 2 different temperatures simultaneously, that is at 37 degrees Celsius and 25 degrees Celsius, and we are going to see different types of morphology of their respective temperature. And for the treatment, we are going to give itraconazole in all cases except the disseminated one, because we will give, for disseminated one, we are going to give amphotericin B. So that is about sporotrichosis. In the next video, we are going to see mycetoma.